The renal disorders lecture has been broken down into two parts. The first lecture portion will actually look at some assessment and diagnostic data as well as a couple of disorders. Remember to review your pathophysiology book to look at the review of the kidney and some of the different functions. Remember that there are hormones that influence the kidney regulation. The three most common of those being vitamin D, which is needed for the absorption of calcium and phosphate by the small intestine. Remember, the parathyroid hormone stimulates the kidney to decrease the plasma calcium levels. The second hormone involved with kidney function is erythropoietin, which stimulates the bone marrow to produce red blood cells. And the third one would be natriuretic hormone, which responds in response to the increased volume and stretch of the right atrium of the heart, as in increased blood volume in the body. And then this hormone inhibits antidiuretic hormone secretion so that dilute urine is produced. So those are three of the major hormones that do affect the kidney. Remember, anytime there is decreased perfusion to the kidney, it's going to lead to that renin-angiotensin system getting activated, which is going to increase blood pressure and that type of a thing. There are three different areas to the kidney, just as a review. There's the cortex, which actually contains the glomeruli. These bring blood and carry waste products from the nephrons. There's the kidney medulla, which has the renal pyramids and tubules in it. And then there's also the renal pelvis, which is continuous with the ureters. And from here, urine goes through the ureters out to the bladder. And remember that each kidney has about 1 million nephrons, and these are used to process blood to make urine. And remember, the nephron consists of the glomerulus, Bowman's capsule, the proximal tubules, the loop of Henle, the distal tubules, and the collecting ducts. And these are essentially what form urine for the body. So before we start looking at different disorders, it's a good idea to go ahead and review your patho so that you remember what's going on with it. When we look at different pictures of the kidney, this actually looks at depictions of the different areas of the kidney that we just described. So gives just a little bit more detail to that. Health assessment with patients that have kidney disorders or just don't have any disorders, but you want to include it as part of your head-to-toe assessment would include to look at urination status, any changes the patient might be having in a voiding pattern, changes in appearances of the urine as far as color, smell, anything like that, concentration. Remember, the color of the urine can tell you a lot of different things. Those patients that are spilling protein in the urine, it will tend to be deep foamy in a deep yellow color. Patients that are having blood spilling in the urine, obviously it's going to be a reddish to rusty brown color or Coca-Cola colored, depending on how much blood is being spilled in the urine. Patients that are dehydrated will have dark yellow or almost brown urine if they also have liver dysfunction. Patients that are taking multivitamin supplements may have bright yellow urine. And so there are also many, many drugs out there that can cause changes in urine color. So listed on your speaker notes are several of what those different types of medications are. So pain, if that patient has any pain in the costovertebral angle area, it could indicate that that patient has some sort of a kidney infection or some other disorder going on. So part of the nurse's assessment should include to look for flank pain, look for back pain, look for mid-abdominal pain and possible vomiting, and crampy spasmodic type of pain, which the patient could have if they had a kidney stone or something like that. Many different blood tests will be ordered to look at kidney function. Probably two of the most common ones that are seen is the BUN and creatinine levels, and those values may vary slightly depending on the lab book that you pick the values out of, but that gives you a general range of what normal values are for BUN and creatinine. Remember that the BUN is going to measure the end product of protein metabolism in patients. So the BUN will be elevated in those patients that have difficulties with vomiting and diarrhea, renal failure, or if the patient is dehydrated. Creatinine is the byproduct of muscle breakdown and is excreted by the kidneys. So the other, you'll see elevations when there's been increased muscle breakdown in patients, but also you'll see an increase in the creatinine levels when patients have renal failure and different types of renal disorders. When about 50% of the nephrons are destroyed, the serum creatinine will be extremely elevated. Another common test that's done is just a basic urinalysis, and please disregard the page that's listed on that. That's from an older book. Your current textbook, it's in the speaker notes what pages to look at. But typically on a urinalysis, we see that a specific gravity of 1.005 to 1.030 is considered a normal value. Remember, if that specific gravity is low, if it's less than 1.005, it can indicate that the patient is overhydrated, has certain kinds of renal disease, or perhaps is suffering from diabetes insipidus. For that patient that has an elevated specific gravity over 1.030, it could indicate the patient is dehydrated, perhaps has suffered from vomiting and diarrhea, or perhaps also has hyperglycemia with diabetes. Ketones should be negative on a routine urinalysis. Protein should be between 2 and 8. Greater than 8 indicates that the patient is spilling protein in the urine, which could be from an infection or kidney disease, or it could be from other types of diseases such as lupus or multiple myelomas, those types of things. The glucose should be negative. Patients should not spill glucose into the urine. If they are spilling glucose, it could indicate obviously diabetes or Cushing's syndrome, and severe stress and infections can also cause a patient to spill glucose into the urine. White blood cells should be normally between 3 and 4. If the patient has on the urinalysis white blood cells over 4, it could indicate a urinary tract infection, or that the patient has kidney disease or has just undergone extremely stressful and strenuous exercise. Remember, urine cultures indicate the presence of infection, and typically culture counts of over 100,000 indicate a urinary tract infection. Other diagnostic tests include timed urine specimens. 24-hour urine collections are probably the most common one that is seen, and one that's done that way is the creatinine clearance test, where it actually over a 24-hour period looks at losses of renal function and looks at the urine volume, urine creatinine concentration divided by plasma creatinine concentration. So normal is between 85 and 135. So those can look at, a creatinine clearance can look at problems with sugar, protein, sediment, electrolytes, catecholamines, breakdown of protein metabolisms, and all those different kinds of things. So remember that some medications can also decrease the creatinine clearance, and two common medications that can do that are steroids and also thiazide diuretics. Additional tests that may be done on the patient with renal disorders include looking at residual urine. This is the amount of urine that remains in the bladder after voiding. The patient is catheterized, and then an ultrasound bladder scanner is used, and to look at how much urine remains. Under 50 milliliters is considered a normal finding. Patients that have over 100, that needs to be reported to the physician. And conditions that can contribute to the retention of urine include BPH, strictures, neurogenic bladder, and all of those types of things. Another commonly used test is just a basic ultrasound of the kidneys that can look for tumors, obstruction, any abnormalities in the kidneys, and that's of course a non-invasive type of procedure. This slide looks at what an actual bladder scanner looks like, so this can actually record the residual urine amount that a patient has. Some additional tests include a kidney biopsy, which would be a very accurate type of diagnostic tool. It can look at the type and stage of a pathological condition involving the kidneys and can help diagnose what type of disorder that the patient is experiencing. It can be done through either a percutaneous or closed biopsy method, or with an open method during surgery, that type of a thing. And typically patients are told in preparation for a kidney biopsy to hold medications that could alter clotting. So any Coumadins, aspirins, anything like that. Patient needs to be typed and cross-matched for blood before the procedure, consent form signed, and answer any questions that that patient may have. Typically the patient will also be NPO before midnight of the procedure. This slide shows an example of a percutaneous kidney biopsy where they actually are going directly through the skin and tissues right into the kidney to be able to pull the biopsy sample out. And as you can see with this, the patient would be in a prone position. It's done typically under a local anesthetic, and the patient's told to take a deep breath while they do insert the needle. The patient will feel pain and pressure with the needle being inserted, and afterwards a pressure dressing is put on this area and a sandbag is put on it for extra pressure after the procedure is completed. So typically things that need to be done with this get also a pre-op set of vital signs to be compared with the post-op set of vital signs, and also a pre-procedure H&H should be done to make sure that the patient is not anemic. And afterwards it's important to keep that patient supine for 4 hours, avoid coughing if possible for that first 4 hours, and check vital signs pretty much very frequently to look for any changes that could indicate the patient could be going shocky. So tachycardia, decreased blood pressure, cool, clammy skin, any of those shock type symptoms should be reported immediately. The patient stays on bed rest for about 24 hours, and the patient needs to be monitored for any blood in the urine, and teach that patient that for 10 to 14 days they should avoid strenuous activity, increase fluids unless that's been contraindicated by the physician, and of course to report any bleeding or infection symptoms that they may have. Additional tests that may sometimes be done to look at renal function would be cystoscopy. This is an example that can look at direct examination of the bladder. It's done typically under a local anesthetic with perhaps conscious sedation, or whatever type of sedation physician prefers. Important to monitor the urine output and voiding pattern of that patient. A little bit of pink tinged urine after the procedure is done is considered normal, but they should not have grossly bloody hematuria afterwards. Patient usually post-procedure is just given mild analgesics and watch for complications such as bleeding, possible bladder perforation, or infection. So this particular type of procedure may be done to remove small kidney stones, which are called renal calculi, or tissue biopsy might be another reason why it's done. If needed, a stent can be left in place if that would be needed during the procedure or anything like that. This slide shows an example of what this procedure would look like. The next few slides are going to review signs, symptoms, and diagnostic treatments used for urinary tract infections. Typically, these are broken down into upper, lower, and uncomplicated urinary tract infections. Upper UTIs would include the renal parenchyma and renal pelvis area. Pyelonephritis would fall into this upper UTI category. Lower UTIs, which are much more commonly seen, would include bladder infections such as cystitis, prostate infections including prostatitis, and urethral infections with urethritis. About 8 million people are treated annually for UTIs. About 1/5 of all women will have a UTI at some point during their lifetime. Most urinary tract infections are caused from E. coli. Probably 80 to 90% of all UTIs are from this organism. Another common organism for the last 10% is staph infections. And unfortunately, about 10 to 15% of all hospitalized patients that have indwelling catheters will also develop urinary tract infections. Uncomplicated UTIs are where there is no structural or functional abnormalities. The patient responds nicely to antibiotics, improves quickly on the antibiotics, and returns to normal bladder function. Complicated UTIs include those UTIs that would have an anatomic or functional abnormality, patients that had some sort of a gyno-urinary type of procedure, patients with catheter infections, or patients that are demonstrating the antibiotics aren't working very well and there's resistance to whatever pathogen is growing with that UTI. Risk factors that put patients higher at risk for developing urinary tract infections would be if the patient has some sort of a history of obstruction within the kidney, ureters, bladder area. If the patient had a history of reflux, the patient had undergone some sort of diagnostic test where they used instrumentation in that area, the fact that women are more at risk for UTIs than men, and the elderly are more at risk. The typical symptoms a patient will have when they have a UTI, the patient will have frequency and urgency. They'll have dysuria where they have difficulty being able to urinate. Typically the urine will smell very cloudy and foul smelling. Patient may also have some suprapubic discomfort. Hematuria may be noted. And some patients are asymptomatic and it's only discovered when urinalysis is done. So typically though, most patients that have UTIs will have symptoms with those patients. So remember that white blood cell counts in the urinalysis will be elevated and bacteria will be noted. So urine culture is going to typically reveal that the bacterial count will be over 100,000. Remember that a urine CNS will take about 24 to 72 hours to get all of the results of the sensitivity back. So typically patients will be started on some sort of a broad spectrum, typical UTI type of an antibiotic. And then once the susceptibility comes back, that antibiotic may need to be changed if it's not appropriate for the organisms that are growing in that patient's flora. On labs, if the patient had a CBC done, there may be some elevation in the white blood cell count with patients that have urinary tract infection. And typically patients are put on medications such as Bactrim and Macrodantin. Cipro may also be used, or another one commonly used is called Penetrex. Patient may be either put on a single dose or a 3-day treatment regimen if they have an uncomplicated UTI. It's pretty much the physician or nurse practitioner preference based upon the patient's symptoms and colony count. Patients that do have increased risk for complications, such as those patients that are pregnant, elderly, are diabetic, or have had a history of previous UTIs, are typically put on a 7-day treatment regimen of antibiotics, or any patients that also have pyelonephritis. So typically the patient is taught to follow up with a repeat urine culture in about 10 to 14 days once they start treatment. Usually the physician will want them off antibiotics for about 48 hours before repeating that culture, just to make sure that the culture is clear and there aren't any bacteria still lingering in the culture. Management of UTIs includes increasing fluids. Unless that patient has some sort of a concurrent condition such as CHF or something like that, they're encouraged to increase their fluids up to 3 liters per day to try and keep that urine more dilute. It's typically also helpful to acidify the urine. It's kind of interesting, there's been some studies done. Patients have been told for years and years to use cranberry juice because it seems to help with getting patients over urinary tract infections, and it was always thought it's because it acidifies the urine. It's interesting, I read an article that another property cranberry juice has is that it has something in its components that actually keeps bacteria from wanting to adhere to the bladder walls, the urethra walls, and all of that mucosa. So it has good properties from that aspect also. Pretty much as far as diet goes, patients are encouraged to limit anything that might irritate the bladder while they have a UTI, such as caffeine, alcohol, spicy foods, tomatoes, those types of things. And to prevent a future urinary tract infection, patients are taught to empty the bladder very frequently. Women are taught to void after sex and use proper catheter care for those patients that have indwelling catheters. Women are taught to wipe front to back and to avoid deodorant feminine products, which can change the pH flora and can make them more susceptible to having UTI infections. So nursing interventions for patients with UTIs include educating regarding the importance of antibiotic therapy, also to teach our female patients that certain things will increase the risk of infections, such as spermicidal jellies, diaphragms, antibiotics, low estrogen levels. All of these can increase the risk. And to teach patients, it's important to keep fluid at about 3 liters per day. Those patients that don't drink much and that stay kind of dehydrated are at higher risk for developing urinary tract infections. Other things we've talked about: acidifying the urine, emptying the bladder very frequently. Patients will be put on pain medications, typically acetaminophen and ibuprofen for discomfort. Pyridium is actually a medication that will act as a urinary tract analgesic, so it gives some relief of that pain and burning and frequency symptoms that that patient experiences. Teaching aspects for pyridium is to let the patient know it turns the urine an orange-red color, and it also can stain contact lenses this color, so make sure patients know that. Warm sitz baths may help the symptoms of a UTI, and a heating pad applied to the abdomen. Of course, we need to watch for the temperature on that and how often the patient's doing it to make sure the patient doesn't get any burns or anything like that. Acute pyelonephritis is actually a more complicated type of infection that the patient can sometimes develop. Patients may have acute or chronic pyelonephritis. Patients that have different types of chronic kidney disorders may experience this. The problem with pyelonephritis is that patient can develop chronic kidney failure, and the symptoms the patient will have will be very similar to a lower urinary tract infection, but typically they will also have a high fever, chills, flank pain, costovertebral angle tenderness, leukocytosis, and on the urinalysis, elevated white blood cells, bacterial counts, and casts will be noted on this. So tissue actually can get destroyed with pyelonephritis, with chronic types of pyelonephritis, and it can lead to chronic renal failure because of that kidney tissue actually being destroyed. So management of pyelonephritis would include antibiotic therapy, anti-inflammatory drugs. Patient may need opioids in addition, increasing fluids, watching urine output, watching for edema, and daily weight for fluid retention, and trying to prevent the patient from developing urinary tract infections. Many patients that develop pyelonephritis will actually require hospitalization. Another type of renal disorder is acute glomerular nephritis. The most common cause of this is a group A beta hemolytic strep infection. And with this particular type of disorder, the patient will have urine and protein and red blood cells noted on the urine culture and on the UA. Patient will have proteinuria, hematuria, azotemia, which is increased blood levels of those nitrogen waste type of products. Patient will also have edema formation, especially periorbital around the eyes. Edema will be noted, and the patient will typically be hypertensive due to the fact that that renin-angiotensin system gets activated. The patient will also have sodium and water retention, fatigue, may have anorexia, nausea, vomiting. Patient may have a headache, and urine may look like a brownish color, Coca-Cola colored, because of the blood that's being spilled into the urine. So remember, with this particular disorder, the capillary membranes are more permeable to plasma proteins and blood cells, And that's just because there's been injury to the glomerulus that's due to that circulating antigen-antibody immune complexes that form, and the infection gets trapped in those glomerular membrane, which leads to inflammation. When this happens, that leads to the permeability where the patient actually loses red blood cells protein and has edema formation. This slide just depicts the normal nephron with the glomerulus, just to show you the area of the kidney where this is located and the functions of the nephron. Remember, we have about 1 million nephron in each kidney. Management of acute glomerular nephritis includes to diagnose it through urinalysis, BUN and CRAT, urine creatinine clearance to look at elevated white blood cell counts. The ESR is actually going to look at the SED rate to look at inflammatory process, and the ASO titer will determine if that patient has had a strep infection, such as strep throat, that type of a thing. And patient is maintained on strict intake and output, weighed daily, vital signs often, especially be on alert for hypertension, and the patient needs to be checked for cardiopulmonary assessment to see if the patient is retaining fluid where it's putting stress on the heart and the lungs and that type of a thing. So in some more severe cases, sometimes plasmapheresis is used for these patients. That removes that antibody antigen complex from the blood, and then the patient's RBCs are returned with albumin and human plasma. So remember, in some of the neuro lectures, we talked about how plasmapheresis was used to remove the antibody complexes with some of those neuro disorders. Medications typically used are antibiotics, immunosuppressants, such as Imuran and Cytoxan, steroids, and usually about 1 milligram per kilogram per day is used as far as a steroid dose, diuretics, antihypertensive, Anacaoxalate enema may need to be used to decrease the elevated potassium levels that the patient may have. Diet is typically a low sodium diet. It's going to be restricted down to 2 to 4 grams per day. Protein will also be restricted if the BUN and creatinine are elevated, and patient is provided carbohydrates, potassium restrictions if they're hyperkalemic. So it's going to depend on what symptoms and lab values that patient actually has. Many patients are also needed to be put on antihypertensive types of meds, and one commonly used antihypertensive is an ACE inhibitor, which can actually decrease the protein loss and slow progression of renal failure also. So it kind of has a twofold effect. And in your book is a nice nursing care plan on glomerular nephritis, so make sure you take a look at that. Watch for infection in these patients, keep them on bed rest, diversional activities, and they can ambulate once that blood pressure returns to normal and the edema has started to decrease. Typically, symptoms will resolve in about 10 to 14 days on average for most patients. Unfortunately, though, 40% of patients will have permanent kidney damage after suffering glomerular nephritis. So patients need to be monitored very carefully for this type of disorder. The next type of kidney problem we're going to talk about are renal calculi, in other words, commonly known as kidney stones. And we're going to follow this particular topic through a case study. We're going to look at a 42-year-old farmer who for the past week has noted a dull ache in his right lower back. At 3 a.m. he woke with excruciating pain in that same region of the back, and it didn't respond to a hot water bottle or aspirin. He spent 4 hours pacing the floor with intermittent bouts of emesis. When he tried to void, he passed a small amount of urine that contained blood, so he ended up going to the emergency room. Many times men that are passing a kidney stone are told that this is probably the closest that they'll ever experience the pain of childbirth. A lot of people will refer to the pain that's involved with passing a renal calculi as very similar to the pain involved with childbirth. Past history includes that this patient had had some history of former UTIs and had had inflammatory bowel disease, no prior surgery, not on any medications. Patient denies the use of alcohol or tobacco, also denies any recent trauma to the back. Diet includes lots of red meat, eggs, ice cream, some fruits and vegetables, but the patient does skip lunch a lot due to his particular vocation as a farmer, and has more soda and peanuts for a snack on a typical day-to-day basis. So when he comes into the emergency room, he's pacing, he's wincing with acute pain. Vital signs are listed there. He's got an elevation in the blood pressure. He's tachycardic. Respirations are slightly elevated too. Skin is cool and moist, and his labs reveal a slight elevation in WBCs. Hemoglobin is okay. Serum calcium is considered normal, but the UA does show that he's spilling protein and blood cells, a little bit of glucose, and has elevation in the white blood cells in the UA. And he's also noted to have 6 to 10 calcium oxalate crystals on his UA. So typically these patients will complain that they have colicky pain on the affected side where they're trying to pass that kidney stone. And a lot of times that's due to hydronephrosis. Probably the most likely cause of his pain, we've already come to the conclusion, he probably has a urinary calculi that he's trying to pass. You can see an example of what one looks like there on this slide. And this one does a nice depiction of showing what the spasm the patient experiences is caused as that stone tries to pass through the ureters. So remember, these patients, we would be actually screening the urine to look for stones and that type of a thing. So risk factors for this patient that supported that he probably did have a kidney stone included the fact that he had a history of inflammatory bowel disease, the fact that he was a male. It's 2.5 to 3 times more common in men than it is in women. The fact that he'd had a history of recurrent UTIs, a decreased diet and fluid intake, activity level changes that might have been decreased, and the fact that he had urine with calcium oxalate crystals. Remember, about probably 75 to 80% of kidney stones will be calcium stones. The rest are typically uric acid stones. And the symptoms a patient has is going to vary with the size and the location of the renal calculi. Remember that the kidneys are going to continue to produce urine, which causes increasing pressure and distension of the urinary tract behind that obstruction. And that's why that patient has such severe crampy pain as they try to pass that renal calculi. So this can lead to hydronephrosis, where there's distension of the renal pelvis and the calyces, and it can lead to decreased renal function. So eventually it can lead to damage of the kidney structures and those types of things. Other tests that may be ordered for this patient to confirm the diagnosis include a scan of the kidneys, ureters, and bladder, a spiral CT, IVP, ultrasound, some labs such as electrolytes, BUN, and creatinine, urine culture, 24-hour urine samples, and actual analysis of the components of the stone. Remember, we said that the calcium stones are the most common ones. The patient may need a cystoscopy to remove the calculi. And remember that there are some things also that increase those calcium levels to make patients more prone for these types of kidney stones, and those would be patients that have hyperparathyroidism, Cushing's syndrome, osteoporosis, and also patients that have uric acid levels with gout. They'll have elevations of those. So how are we going to treat it once we've diagnosed that this patient does have a renal calculi? Probably one of the most common methods is through ESWL, which is extracorporeal shock wave lithotripsy. This is where acoustic shock waves are actually used under fluoroscopic guidance, and it actually picks up the density of the stone. That's what will stop the shock wave. The shock wave actually shatters the stone, but it doesn't do any damage to the soft tissues and that type of thing. If that is not appropriate for that patient, or if that didn't work for that patient and the patient still has symptoms and pain, then the patient may actually have to have a percutaneous nephrostolithotripsy, and this is done typically under general anesthetic, where a fine needle is inserted, the stone is broken up, and then the fragments are then evacuated out. So this patient will have a nephrostomy tube after this particular procedure, and there's a great care plan in your book that you can take a look at to learn a little bit more information about this. Remember that stone is going to need to be removed if it's causing severe obstruction, infection, unrelieved pain, or if the patient also has serious bleeding from it. After the patient has any type of surgery like this, remember that the patient will need to have report any leaking from the incision site that they may have, signs of infections and things like that. Some stats I was able to find is that unfortunately about 50% of patients will redevelop kidney stones within about 5 years. This slide just shows the difference between the shockwave therapy on the left versus the patient having more of an invasive procedure with a nephrostomy tube placed on the right. So other types of procedures, we talked a little bit ago that the patient may need to have a ureteroscopy done, where the scope is placed and the stone is removed with a basket or graspers. The patient will have a stent in place if this type of procedure was used. It's an open surgery. The patient will have an incision in the area, and this just shows a depiction of what that actually looks like if the patient has to go in and have that done. So remember, the patient should increase fluids after this procedure. And some other things that would probably be helpful as far as diet modification for our patient in our case study would be to encourage that patient to increase fluids up to 3 liters per day, go on a low oxalate diet. So in other words, limit dark green types of products, leafy greens, those types of things, nuts, limit chocolate. Also beer, colas, tomatoes, green beans, and asparagus are also considered high in oxalate. Patients should be put on a low sodium diet, probably a limitation of about 2 grams per day. Low purine may also be needed, so in other words, the patient needs to limit meat to just 2 moderate servings per day. Increase citrus fruit juices to increase the acidity, and restrict calcium, because that's probably the type of kidney stone he had. So he may need to limit calcium to only 2 servings per day. So remember, not just milk and yogurt and common things we think of have calcium in them, but also beans, lentils, chocolate, cocoa, dried fruit, and some canned fish also have a lot of calcium in them. So tuna is not one of the canned fish, but tell the patient they should just check labels to look at calcium levels on products that they eat. So other types of teaching we would want to include, we've already talked about the fluids, but empty the bladder on a regular basis. Don't hold it all day. Teach on medications the patient may be put on, such as thiazide diuretics or xyloprim for uric acid stones. Look at the signs and symptoms for renal calculi reoccurrence, and look for signs of any urinary tract infections symptoms that the patient may have.